Okay, so welcome back to this next video in which we are discussing heart failure and heart failure medications. Okay, right. So in the previous video what we discussed was what heart failure was, and we discussed the difference between left ventricular failure, where the left ventricle is capable of too small a stroke volume, and then the right ventricular failure, where the right ventricle is having problems and is ejecting far too small a stroke volume. However, we also said that usually in heart failure you get both left ventricular failure and right ventricular failure, and that's certainly going to be true in the hypertension-induced heart failure that I'm going to discuss with you now. Okay, right. So what we now want to discuss is the pathogenesis of heart failure as a result of chronic hypertension. Okay, so I'm going to draw a flow diagram for this. So the starting point then is that you have chronic hypertension. Okay, which means that your arterial blood pressure is going to be too high for an extended period of time. So hypertension refers to too high arterial blood pressure. Okay, chronic means that it's going to be for a long period of time. Okay, so let's think what effect is this going to have on the heart? Okay, well, the first thing that I want to say is we are firstly going to paint a very simplified picture of this. Okay, this is an incredibly difficult disease to understand, okay, and it's because there are so many different things happening at once. We are going to start off by completely ignoring neurohormonal mechanisms. We're going to assume that the neurohormonal mechanisms, for instance, the sympathetic nervous system, the renin-angiotensin-aldosterone system, antidiuretic hormone, we're going to assume that all of those are gone. They're not there, okay? We will have to put them in later, okay, but we have to build this up gradually, okay, because it is a complicated pathogenesis. Okay, so we're going to start off by assuming that the neurohormonal mechanisms are not there, okay, and we'll put them back in later on. So, what does chronic hypertension then cause? Okay, well, let's get back our picture of the cardiovascular system and think this through. So, arterial blood pressure is far too high, higher than it should be, okay, for mechanisms that we're not going to discuss. We're not going to discuss the pathogenesis of hypertension, that's a whole different topic. We're just going to start and assume that it's there now, okay, so arterial blood pressure is far too high all the time, basically, so mean arterial pressure is too high. What effect is this going to have on the left ventricle? Well, remember, in order for the left ventricle to eject blood into the arterial system, it has to firstly get the blood inside the left ventricle up to a pressure that is higher than the arterial pressure. If the arterial pressure is now too high all the time, then that means that the left ventricle is going to have much more difficult time ejecting blood into the arterial system. Indeed, it's going to have to get that blood up to a much higher pressure. Okay, and that means that the tension in the wall of the left ventricle that you're going to have to generate is going to be greater. So the afterload on the heart, that tension in the wall of the heart at the point where you finally get left ventricular pressure up to the point that it's high enough to eject blood into the arterial system, this is going to increase. Okay, so remember, afterload, that's what it strictly means. It strictly means the tension in the wall of the heart that you have to get up to in order for the pressure within the left ventricle to be high enough to eject blood into the arterial system. But really the colloquial meaning of it, the meaning that everyone sort of uses in an offhand way, is it means how difficult is it for the heart, and we're specifically thinking about the left ventricle at the moment, but we'll move on to thinking about the right ventricle in just a moment. How difficult is it for the left ventricle to actually pump blood into the arterial system? That's, if you like, the sort of informal definition of afterload. That's what it really means. It's how difficult is it for the left ventricle to pump blood into the arterial system. Okay, so if you have chronic hypertension within the arterial system, then what that is going to mean is that the afterload is going to be increased. Okay, so think of afterload as just meaning how difficult it is for the left ventricle to pump blood into the arterial system. So the left ventricular afterload is going to go up. Now, what is the effect of the left ventricular afterload going up? Well, it means that the stroke volume is going to decrease. If it's harder to pump the blood into the arterial system, then the actual amount of blood that the left ventricle will be able to pump into the arterial system is going to be decreased. So the stroke volume from the left ventricle, and I'm going to put this here, left ventricular stroke volume. It's a bit of an odd thing to put, because really the stroke volume of the right ventricle and the left ventricle should be the same, but you'll see why I'm going to specifically specify the amount of blood that is being pumped out of the left ventricle is going to go down. Okay, we'll have to talk about the right ventricle in a moment, so it's useful to think in terms of a left ventricular stroke volume and a right ventricular stroke volume for the time being. Okay, so left ventricular stroke volume is going to go down. Now, what effects is the left ventricular stroke volume going down going to actually have? Well, the first effect that I want to talk about is that left ventricular stroke volume going down is going to cause mean arterial pressure to go down as well. Okay, and I want to explain exactly why this is, but first I should probably say that if left ventricular stroke volume goes down, cardiac output is going to go down. I'll put that in brackets here. Okay, because remember, cardiac output is just how much blood you eject on each beat times how many times you beat in a minute, so times heart rate. We're assuming that heart rate hasn't changed yet, so of course if stroke volume goes down, cardiac output goes down as well. Okay, so why does cardiac output going down cause mean arterial pressure to go down? Okay, well, let's get our picture of the cardiovascular system back up. Okay, so we saw how the mean arterial pressure is approximately 90 millimeters of mercury. The central venous pressure is around 8 millimeters of mercury. What is it that maintains that fantastic pressure differential? Well, of course, it's the heart. The heart is continually grabbing a bucket load of blood from the venous system and chucking it into the arterial system, and that's what creates this pressure differential. If you took out the heart, if we just vanished away the heart, then of course what would happen is blood would flow from the arterial system to the venous system because of the pressure differential, just by the laws of fluid dynamics. Okay, and then you'd take blood from the arterial system to the venous system, and that would reduce the arterial system pressure and increase the venous system pressure until the arterial system pressure equaled the venous system pressure, and then you'd have no net flow. So basically this pressure differential would be lost if it was not for the heart continually grabbing blood from the venous system and dumping it into the arterial system. Okay, so it's important to understand that mean arterial pressure is maintained by cardiac output, and if you reduce the amount of blood that the heart is bucketing from the venous system into the arterial system, then naturally, of course, mean arterial pressure is going to go down because the pressure gradient is going to go down. Okay, so there is a nice equation that people often use when discussing this, and I'm just going to put that up now, okay, because it will help us later on. So this is that mean arterial pressure is equal to cardiac output times another hemodynamic parameter that we haven't seen yet, which is TPR. And TPR stands for total, that's the T, peripheral, that's the P, and then resistance, that's the R. Okay, so what does this mean? Well, total peripheral resistance means how difficult it is for blood to move back from the arterial system to the venous system. So let me explain this in more detail, so I'll get my picture back up. Okay, so we've said that mean arterial pressure is going to depend on how much blood you are moving from the venous system to the arterial system. That makes sense. Okay, so it's going to increase as cardiac output increases. But it's also going to depend on how easily blood can move from the arterial system back to the venous system. Because if it's really difficult for blood to move from the arterial system to the venous system, then the blood that you move will stay there for longer, and that will mean that mean arterial pressure is going to be higher. Okay? If instead it's much easier for blood to move from the arterial system back to the venous system, then of course blood will gush back as soon as you tip it in, and then mean arterial pressure will therefore fall. Okay, so total peripheral resistance captures this concept of how easy is it for blood to move back from the arterial system to the venous system. And it's all about the arterioles. The arterioles are what determine the total peripheral resistance. They determine how much blood can move back from the arterial system to the venous system and how fast it can move back. Okay, and that's why they're known as the resistance vessels. Okay, so total peripheral resistance then is this concept that captures how easily it is for blood to move back from the arterial system to the venous system. Okay, so the higher total peripheral resistance is, the more difficult it is for blood to move back from the arterial system to the venous system. So as TPR increases, i.e. as it becomes more and more difficult for blood to leave the arterial system and go back to the venous system, then of course mean arterial pressure is also going to increase. Okay, so that's a very important formula that we will continually be coming back to. Okay, so we're assuming at the moment that total peripheral resistance has not changed, okay, but cardiac output has gone down, and therefore mean arterial pressure will also go down if this number here has gone down. Okay, so mean arterial pressure is therefore going to go down. Okay, what's the other effect of left ventricular stroke volume going down? Well, it's also that blood is going to back up in the pulmonary system. Okay, so let's think about this. If the left ventricle is pumping less blood from the venous system, well, from the pulmonary venous system here, into the arterial system, then of course the blood's going to back up in the pulmonary venous system, okay, then it's going to back up in the pulmonary arterial system. Okay, so what's going to end up happening is pulmonary venous pressure, PVP, is going to firstly go up, and then it's going to get worse, it's going to back up into the pulmonary artery system, so PAP, pulmonary artery pressure, is going to go up, okay, and then the right ventricle is faced with the exact same problem that the left ventricle originally faced. Now the right ventricle has a pulmonary artery pressure that's much, much higher than it should be. Okay, so again, it's exactly the same process. Now the right ventricle is going to have a much more difficult time pumping blood into the pulmonary arterial system, and therefore the right ventricular stroke volume is going to fall. Okay, so now this is why it's useful to distinguish between left ventricular stroke volume and right ventricular stroke volume. So right ventricular stroke volume is going to fall, and of course it's going to fall to the same level that left ventricular stroke volume would fall. Okay, so that you can establish an equilibrium. Okay, so right ventricular stroke volume is going to fall. What effect then is right ventricular stroke volume falling going to have? Well, it's going to also help to reduce down pulmonary artery pressure a little bit, okay, but it's also going to mean that blood is going to clog up now in the central venous system, okay, because the right ventricle is now moving less blood from the central venous system into the pulmonary artery system, so this is going to mean that central venous pressure goes up. Okay, so there we have this first part of the flow diagram then. We've got mean arterial pressure going down and central venous pressure going up. And the other important thing is that we've got pulmonary venous pressure going up as well. Okay, so let's now think about what effect this is going to have, because actually these things are going to be quite helpful. Mean arterial pressure going down is going to be quite helpful for increasing left ventricular stroke volume back up a little bit. In addition, raising pulmonary venous pressure and central venous pressure is also going to be helpful for raising stroke volumes as well. Okay, so let's think this all through then. So firstly, let's start off with mean arterial pressure going down. That is actually going to have a beneficial effect on the left ventricular stroke volume, because remember, why was the left ventricular stroke volume too low in the first place? Well, it was too low because mean arterial pressure was too high. You had the chronic hypertension. Okay, so now we brought back down mean arterial pressure slightly by reducing cardiac output. That's going to mean that we can now increase left ventricular stroke volume back up again. Okay, of course it's not going to go back up to what it should be, Okay, because if it went back up to what it should be, then you'd maintain cardiac output at what it should be, and that would raise mean arterial pressure back up to what it was prior. Okay, so you can't do that. That's not what's going to happen. Okay, that would just be a chronic fluctuation. Instead, what's going to happen is you're going to re-establish an equilibrium, okay, somewhere in the middle. So left ventricular stroke volume will go back up from what it was here, but it's not going to go back up to the healthy level. Okay, so left ventricular stroke volume is going to go up. Okay. In addition, obviously, when right ventricular stroke volume falls down, pulmonary artery pressure will go down a little bit. Okay, and that's also going to help reform an equilibrium, basically. Okay, so a similar thing's going to happen there. Right. Now let's think about what the effect of having raised pulmonary venous pressure and central venous pressure is going to do. Okay, and to understand this, we need to know something about what's called the Frank-Starling law of the heart. So I'm going to tell you about the Frank-Starling law of the heart. Okay, so I'm going to start off our discussion of the Frank-Starling law by telling you about the experiment that these people did. Okay, so what you can do is you can remove the heart of some poor animal. Okay, and you can set up basically an artificial cardiovascular system. Okay, so let me draw a simple picture for this. So you can put in an input tube here, and let's just say we've got one ventricle here. Let's say this is the left ventricle. Okay, here. And then you've got an output tube here. And the idea is that you can control how much goes in, and you can measure how much goes out. Okay, so let's say this is the left ventricle here. Okay, so basically what these people found is that if you put more fluid into the left ventricle before it contracts, then the amount of stroke volume you get out is increased. Okay, so let me say that in fancy physiology terminology. If you increase the end diastolic volume, if you force more fluid into the left ventricle, or indeed the right ventricle, before systole, okay, so you stretch the heart out more, okay, and remember there's a fancy word for that. You're going to increase the preload, you're going to increase the stretch of the heart wall, basically, by the end diastolic volume. Okay, if you fill the heart up to a bigger volume, okay, what then happens is the stroke volume increases. The amount of fluid that the heart is going to eject is going to increase. Now you might think, well, isn't that the most obvious thing in the world? Okay, but then when you think about it a little bit more, it's not so obvious at all, actually. Okay, because in order to eject a bigger stroke volume, you have to expend more energy. It takes more energy to it takes more energy to expel a larger stroke volume of fluid. Okay, where does that energy come from? Well, it can only come from the contraction of the cardiomyocytes. Okay, so that means that the actual force of contraction of the left ventricular wall must have increased so that it can expend more energy to force out this stroke volume. Suddenly, this becomes not so trivial. Okay, we are saying that the bigger the end diastolic volume here, the bigger the force of contraction of the left ventricular wall. Okay, we're saying that the left ventricle will contract more if you stretch it more. So this is what the Frank-Starling law is. If you stretch the wall of the ventricle more, if you increase the preload, okay, and I'm just going to make sure this is in view. Okay, if you increase the preload, the stroke volume is going to increase. Well, actually, before that, let's say the contractility of the myocardium is going to increase. So contractility is going to go up, and that's going to cause the stroke volume to go up. Okay, and that's what the Frank-Starling law is saying here. Okay, so putting this in context here then, we're now saying that the central venous pressure and the pulmonary venous pressure are going up. Okay, those are what determine the preload. Okay, remember, when a ventricle, whether it's the left ventricle or the right ventricle, relaxes, okay, firstly it has this active process of relaxation, and then it fills up with blood simply because it's returning to its natural volume and there's space for the blood to come in. But then you go further. Then whichever venous system we're talking about, the central venous system or the pulmonary venous system, is going to force additional blood in by stretching the wall of the heart that little bit. Okay? If the central venous pressure and the pulmonary venous pressure are now higher because the right ventricle and the left ventricle have decreased their stroke volumes. Okay, what's now going to happen is the movement of blood into each of the ventricles by this stretching part is going to increase, which means that the end diastolic volume in both the right ventricle and the left ventricle is going to increase, which then means that the stroke volume is going to increase by the Frank-Starling law of the heart. So in fact, both these things help to increase stroke volume. This one helps to increase left ventricular stroke volume back up, and this one helps to increase right ventricular stroke volume back up. Okay, and I don't know why I've put a dash there all of a sudden, get rid of that. Right ventricular stroke volume back up. So we're helping overall to increase the stroke volume of the entire heart, because remember, the right ventricle and the left ventricle are coupled in this incredible way. Okay, you need the right ventricular stroke volume to be the same as the left ventricular stroke volume. So this is going to help bring the right ventricular stroke volume and the left ventricular stroke volume up. Okay, so basically, to summarize, if you have no neurohormonal mechanisms, and unfortunately you do, this is what the heart would do, okay? If you have chronic hypertension, yes, it would decrease the stroke volume of the heart slightly, okay? But it wouldn't be as much as you would initially think, because a new equilibrium would be formed. Firstly, mean arterial pressure would be decreased slightly, okay? And also, you'd increase the pulmonary venous pressure and the central venous pressure, and these would increase the end diastolic volumes in both of the ventricles and thereby help to increase stroke volumes back up. Okay, so basically you'd form this new equilibrium using mainly the Frank-Starling law of the heart here. Unfortunately, this is not what happens, or at least this is only part of what happens. Okay, the neurohormonal mechanisms are going to come into play, and the reason the neurohormonal mechanisms are going to come into play is that if we allow this system to work, mean arterial pressure is going to go down, okay, and there are very, very strict homeostatic mechanisms that respond to mean arterial pressure going down. Okay, mean arterial pressure going down is seen as a homeostatic emergency. Okay, and there are very powerful mechanisms for bringing arterial pressure back up. And this is what we're going to see later on. The problem is that these actually end up having deleterious effects for the heart. And in fact, many of the medications for heart failure actually work by stopping the neurohormonal responses and trying to return it just back down to this, where the heart sort of sorts out the problem on its own and keeps the stroke volume high enough to maintain a decent blood flow to the viscera. Okay, it's not going to be the healthy stroke volume, but it's not so bad that it's going to kill you. Whereas the problem with the neurohormonal mechanisms is that they start this chronic deleterious effect on the heart, where the heart just becomes weaker and weaker and weaker and weaker. Okay, right. So we'll call it there for this video, and in the next video what we'll do is we'll turn our attention to the neurohormonal mechanisms.